Over to you.
All right. Well, repeat offenders. My name is Bill Vashis, and we'll be talking about based on the Joint Trauma System in route care patient packaging CPG. So hopefully you guys have had a chance to look at it. I think, like I said last time, when I read these CPGs, I know that they were designed with a plan in mind and for a target audience, but I think that their aperture is pretty wide, and so there's a lot of information in there that is above and beneath most of the providers in this room. So it really depends on your background. When I put together the outline, I was very
Hey,
agnostic.
Bill. Bill, there's a lot of. Are you? It sounds like you're moving something around, is making a lot of noise. What's hitting your microphone?
Well, I had the paper sitting on the laptop, so I
Ah,
just could look down at it, so it's scraping it. So yeah.
fair enough.
Um, so when I put the outline together for this, I kept it very agnostic. So I didn't care about whether it was a ground vehicle or an air vehicle. I will make references to both, realizing that situations change. Um, I Some of the perspectives are from me as the sole provider, meaning I took care of the patient on the ground and I'm not transferring the patient over to somebody else. I'm just changing from a ground treatment area to a moving platform, whether that's a vehicle, whether that's an aircraft. And so we'll make some references. And if you have personal experience or questions related to anything that we're talking, go ahead and throw a hand up and we'll discuss it. Uh, the biggest thing about this is it's a discussion or a chat, not a lecture. I'm going to go through an outline that we have from based on the CPG, but this is a discussion so we can all learn, because I guarantee I'm not the most experienced person about in route care in this group. I have enough and valid experience, as do each of you. So, sharing that, we can all collectively learn from each other. So, we'll just guide this. So, I broke down the CPG into, and I tend to oversimplify things. So, I took the CPG and I broke it into just four main areas, and that's planning, execution, pearls to consider, and the appendices that are in the CPG. So, with that in mind, we'll talk about planning first. Now, there's two main elements in the planning that I focus on. One is the ground team, or the sending team, and then the other is the in route care team or the receiving team. So both of those, at the onset of notification for patient movement, both of them need to begin a planning process. And so these are the ideas. I think Eric pointed out some things um, last time, that everything that the in route care team would plan for, the ground team that's about to hand off the patient should think. So, it's redundancy in the process. And so, um, we'll start off with the ground team. So I have a patient. I need to get them ready for movement, whatever that entails. So I want to talk about patient packaging, how I'm padding them for comfort and to prevent ulcers or any other injuries that's going to take place. What kind of protection I'm going to give for them, whether it's eye, ears, helmet, flotation devices, anything protection that the patient needs to be from the environment, whether that's thermal and heat producing, you know, packaging, all of that. I want to make sure that I prepare all of their personal effects. So their IDs, any sensitive items, if it's military, secured high value items, anything that really needs to be secured that will not travel with the patient, that will eventually catch up with the patient or get put into the right hands. Identification, any orders that they need, any documents that they need to travel with. All of those things are the responsibility of the sending team to put together. Sometimes that's just uh, sanitizing them to take any operational stuff off of them so it doesn't go with the patient when they get into a non-sensitive area. Then I want to communicate. I want to communicate with the transport team or whatever facility is going to receive my patient. So typically that's done through a 9-line for military or NATO and a MIST report. One of the things that gets overlooked is the initial report, the initial 9-line or the initial MIST report on a patient is wrong initially. And that's as simple as right side of the patient versus the left side of the patient, upper extremity versus lower, one extremity versus multiple extremities, central truck, head injury. The initial reports are generally wrong because everything is loud, everything is fast, everything is confusing, and they're trying to just get the information started. Like they want to get the transport team alerted and moving as soon as possible. So they're going to say something. And a lot of times it's, well, it works both ways. Sometimes the injuries are exaggerated because they don't know, and sometimes that they're minimized because they don't know. And the worst thing that can happen is you get there expecting one thing and it turns out to be something dramatically different that you're not prepared for. So as the ground team or the sending team, you want to make sure that as your information becomes more accurate, you convey that information up the channel. And so no one knows that patient more than the team that's taking care of the patient wherever they are. And so as information becomes clarified, as you perform care, all of those things, you need to convey that and put that in the update and prepare the handoff that's going to happen when you hand this patient off to the transport team. So that's something you want to consider. And then as part of your planning, you know what that patient, the care that that patient needs. And so because the whole purpose of in-route care is to ensuring continuity of care for that patient, you need to decide, is this procedure that this patient is going to need, is it better for me to perform it before I hand them off, or is it something that the in-route or transport team can do in route? And like I said, there's no real right or wrong answer. There's just consequences. But I would say generally, if I can perform a procedure on the ground in a stable environment, the likelihood of success and the decrease in the amount of complications are going to be the case if I can do this on the ground in a more controlled environment than somebody doing it in the air. That's my 2 cents. Anybody have opinions either way?
Yeah, it's interesting working on the ground ambulances in Hungary. They have a standard rule that when you need to intubate, if you're en route and you need to intubate, they pull the patient out of the ambulance and have a place that's lighted and 360. That's the only way that they'll do it.
Okay. How's that working out for them?
Well, maybe their research says the pass rate's better, but I mean, intubating in the back of the ambulance or back of heli is as rough as it is. It's constrained and light and everything else. You can't really land a heli halfway through just to do a. So I think they should have. I think they should have pulled that trigger before they decided to go.
Yeah.
No. May I say something?
Yeah.
What I learned is when we're doing some medevac, especially with the helicopter, but even an ambulance, if we decide not to intubate the patient and start doing transport, if the patient deteriorates, you already failed. So in the dark side, because everything can go wrong. If you're expecting the patient is going to crash and is a likelihood to patient to crash, we need to intubate the before starting transport. It's like burns. If you know the patient's got a burn airway, but still breathing is fine, but you know in 20, 30 minutes that airway is going to shut. So it's better to intubate early. Right? I know all the other problems to keep the patient sedated and so forth and skill set, but if we don't do it, we are expecting, it's Murphy law. We expect it to all things go wrong.
Yeah, no, I concur. That goes along with my thought process of when I plan, and I think this through pretty much everything in medicine. What is the most likely thing to happen, and what is the most dangerous thing to happen? And yes, if I anticipate that they're going to have airway complications, I'm going to be more aggressive when I'm managing that. But as we'll talk about later, nothing is free. If I take somebody's airway, that means they have to be sedated and they need full-time monitoring. And if I've got multiple patients and one person on the aircraft, I've basically not only just tied their hands, but I've, binded their feet a little bit too. So nothing is free. And so, yes, it's a possibility. So I think all of that has to go into the reality of whatever you're going to end up doing. But, then it goes into, the patient better than the person on the aircraft. And are they able to, is it more than likely or less than likely they're going to be able to make the flight without, losing their airway? And do you know the capabilities of the person that's in the aircraft? Can they do a crike? You know, so can they do it in the aircraft? Are they trained? If that's something that they're not even capable of doing, then that factors in your decision to do the airway, secure the airway before they get on the plane. So all of these are factors, and a lot of times this information is unknown. You might not know the person that's going to be on the aircraft. You might not know their capabilities and training. You might expect one thing, and what's the most dangerous thing is they can't do what you think they can do. So all of these are factors. So there's not a simple answer in this at all, but you need to be thinking about it, right? And have a reason for doing what you do. Like that's the key is, oh, well, I had time, so I would do it. That that might work out, but it might not. So those are things to consider. Now, as the sending team and prepping, there's tons of things that we can think about, and I think some of them are covered in the execution part. So, to reduce the redundancy, I'll cover them there. But when I hand that patient over to another team, or I just go from being stationary to now being mobile on some platform, vehicle or air. If I'm the team that's receiving the patient, if I'm the in-route care team, I want to communicate as much as possible in the planning process with the team that's taking care of the patient, right? So whoever sent the 9-line or gave me the mist, I'm going to try and contact them if I can and clarify, if there's any information in the report that's confusing or that doesn't seem right, then I'm going to try and clarify that information. I'm going to clarify if it's one or more than one patient, right? Do they need special equipment or do they need standard equipment? Now, depending on if you're working in a familiar environment with teams and you understand them, like in the past, I would get on the medevac helicopter when our guys were doing missions in the area. So I would work with them. So I knew what equipment and what capabilities the medics had on the ground. And so I knew that what type of litters they had. So I would carry those litters in the aircraft so that when they handed their patient off on a litter, I would just give them a brand new litter to trade off so that the ground team wasn't missing vital equipment that they might need, for the mission going forward. So if you have that familiarity, you might be able to offer that capability or basically prevent that team on the ground from being without some equipment. So I'm going to clarify all of their stuff. Then I'm going to start gathering all of the patient stuff. And Eric pointed out last time that the planning team on the ground needs to prepare and protect that patient. But if I'm in the team that's in the aircraft, I'm going to make sure that there's hearing and eye pro for the patient, because they're going to get on my bird. Do they need a helmet? Are we going to go over large bodies of water? Do they need flotation devices, et cetera, those kind of things. And then keeping them warm, not only to prevent barriers from them being exposed to the environment, but putting heating elements inside. So I'm going to provide that. If I know we're at altitude and it's much colder, I need to be able to protect that patient, because once I take them, they're mine. They're my responsibility. So I need to be responsible for it. Now, hopefully the ground team planned for it and the patient is packaged appropriately. But once again, even that's not free, because if the patient is wrapped up like a cocoon, I got to break into that cocoon, because one of the next things I have to do is in my execution phase is I have to assess the patient. So, you might prevent him up and, wrapped up a beautiful package with a pretty bow, but I got to tear that shit open because I got to look at the patient. Because there just might frankly not be enough time for you to convey a good, proper patient handover. So even if you do give me a good one, I still need to do an assessment on my patient. In the CPG, they mention tactical requirements, but I'm gonna forego that because I think that could be its own separate lecture. We'll just keep this to non-tactical and just general patient movement, because I think the topic is complicated enough. One of the pearls that's perfectly appropriate to this part is planning. When you're planning, you need to plan for the duration to be 2 to 3 times longer than you would expect. If I think, Angela, you were talking about just make it 20 minutes. Oh, I think it's great planning for 20 minutes, but you need to plan for 40 or 60 minutes in case there's traffic or you get a flat tire or, if you're ground movement. So plan for the movement to take longer, by 2 to 3 times, just so you're not completely shattered by a delay. Any comments or anything that we've forgotten in the planning aspect for the ground team or the in-route care team? All right. So we'll get into execution. Eric.
Execution.
Yes. All right. So if I'm the sending team and I'm about to do the ground transfer, I'm going to conduct a patient handoff. Now, we mentioned this before. The CPG specifically lists, Eric, there you go. The, doing the handoff, the handoff that the CPG mentions is March, and March isn't a patient handoff mnemonic. It's a point of injury mnemonic. And so we would recommend S-bar or what do you use there? C-Pro?
CPRO.
Yeah.
Cap
C-Pro.
refill, pulse, respiratory, and oxygen.
Okay. And I think that those are any mnemonic that you typically use, and a lot of pre-hospitals will use, and even nurses will use S-bar, right? So what is this? Status, background, assessment, and recommendations. For the prolonged field care and what we've taught at Ragged Edge is strings. It's a mnemonic that I came up with that is I think is a comprehensive patient handoff. Strings is used in the current PFC prolonged field care vital chart, trending sheet, the flow sheet, and it stands for S is status. So is your patient sick or not sick, stable or unstable? So you cover their status. And then TRI is treatment related to injuries. That's what it started off as. And then we kind of expanded to treatment or tests related to injuries or illness, because then it covers both traumatic patients and sick patients. And so essentially what TRI does is it tells you what treatment you did and why you did it. So I started 2 large bore IVs to run 2 liters of fresh whole blood for the traumatic amputation of the lower extremity, which we applied two tourniquets to control external hemorrhage. We've given TXA and calcium, and we're controlling their pains with bumps of ketamine, right? So basically that's a lot of information, but it says what I did and why I did it. And it's easier for me to remember because I was there when I did the treatment, and it's easier for you to remember because I kind of told it to you in a story. And it's pretty common, and what I did should make sense with why I did it. And you can connect that versus most of the handoff mnemonics that we have where it just lists a series of injuries and a series of treatments, and I'm relying on the other person to put those things together and why I did it. And it's harder to identify gaps, right? Because if I say I did this and this and this because of this, in your head, if you go, hey, well, did you do this? Because it would make sense that you would also do this individual treatment, then it's going to stick into your head and you're going to ask me to clarify. Maybe I did or maybe I didn't, right? So then the next thing in the strings mnemonic is N, and so it's next. So if every patient evac I've ever been involved in, I'm about to do something for this patient when the aircraft lands. And then I have to decide, do I do the procedure before they take off? I'm in essence sometimes delaying transport because I need to finish this procedure, or do I just need to tell that receiving provider that, hey, he's due for his next dose of pain medicines. He's due for this. Here's the next thing that I was about to do. It's, so it lets them know for continuity of care what they should do or where they are in the treatment protocol. That provider may or may not heed what it's, what I recommend, but I'm at least letting them know when in my process of treating the patient, this was the next thing that I'm about to do. You might want to start there, right? And then that's on them. But I'm trying to make it easier for continuity of care to be maintained when I hand it off to somebody else. The next thing is G, and that's gather and give, and that's all the documentation. For all the other stuff, all the other mnemonics, giving documentation is an implied task. It's required, but it's an implied task because the mnemonic doesn't mention it. In strings, G is gather and give, so it kind of puts it in there as a trigger to remember to hand off all the documentation. That's probably one of the biggest gaps of the multiple decades long war, and that a lot of that patient point of injury care is lost because that documentation may have been transported with the patient, but it's been dropped at some point in the chain. It's a gap. And then the last S is for any serious concern. So if I'm really worried about something about the patient, something, because I've treated this patient longer than anybody else. When I hand it off to somebody else, I let them know what my serious concerns are. What am I really worried about? Am I worried about, loss of internal control of hemorrhage? Am I lost about converting a tourniquet? Am I concerned about, uncontrollable pain or mental status changes? Any of those things. Whatever I'm worried about, I'm going to tell that to the provider last. These are my serious concerns. The thought process behind that is, if it's the last thing that I tell you, it should be the first thing you think of when the patient's condition changes. If it changes abruptly, you're going to go, well, why the hell did this happen? Why did his blood pressure drop out? Oh, Bill was worried about breaking some internal clots because of, it's stable while he's stationary, but he's been getting nauseous, and I'm worried that he's going to vomit, and that's going to cause some increased abdominal pressure and might break some clots, right? All of those things. This is what I'm worried about. So at least I'm giving you a head start on potential causes for a change in the patient status. But that's strings in a nutshell. It is in the current PFC flow sheet, and we tried to get it published in the JSOM, but we were using some anecdotal evidence, and they want studies. And so we're working on that to try and make that out. But it's out there, and we do believe it works well. Go ahead, Eric. You muted.
Sorry, that was just a finger touch that wasn't supposed to happen. Sorry.
All right, cool. All right, so that's the ground team transferring or performing a handoff to the transport team. Now, if I'm the receiving team, right, the in-route care team, and I just received handoffs, now's the time for me to ask any clarifying questions. Now, that's a luxury, because a lot of times you're under the rotor wash, you've got a limited amount of time, you're going to be on the ground for 30 seconds or more, or less, and you're going to be in the air. So you might do a lot of hand and arm gestures. You might be limited communication wise, is in their commo system might not interact with your commo system. And so you both have to scream into ears. All of whatever you have to overcome, you need to ask those clarifying questions if possible at that time. And then once you own the patient, if you're in the in-route care team and you take that patient's yours now, you need to do an assessment. And so whatever that process is, everyone's got a preference that they do, whether it's a head to toe, whether it's a systems evaluation, or whether you just do a primary and a secondary exam. Whatever you do, be consistent in what you do. Make it second nature. Do it so that they could wake you up at 2:00 in the morning, stone cold, and you could do an assessment on your patient. That's how familiar you should be with doing whatever assessment you do, because you need to not think when you're doing it. You should have it down. And so you should know what normals are, and any abnormal will jump out at you. That makes it easier for you to remember when we talk about documentation towards the end of this execution, like how do you document your patient? Well, a lot of the times, and I'll self-admit, I do it after the fact. If I can hand jam a couple of vital signs on a piece of tape or something while we're doing it, that's a technique. But a lot of times I get all the way to the very end, and then I go back and I remember and I document. And for me, it's easier to remember any abnormalities because I'm so familiar with my normal exam. And if I do the same exam over and over and over, I know exactly. And if it was normal, I don't think about it. If it's abnormal, then I go down that rabbit hole and find it. But all I have to remember is the rabbit hole, because everything else was the same. So that makes it easier for me. So if you're early on in your process, develop something that's very consistent that you can do every single time. Even when I'm just doing normal clinic visits and I do a physical exam on somebody, I do the same exam for everybody until I find an abnormality, and then I go down that rabbit hole. And then when I document based on whatever the physical is. So if it's a standard physical, or if it's a halo scuba physical, or a flight physical, or anything that's a required documentation for that physical, well, then I make sure that I cover that. But my exam doesn't change. Like I'll even do neuros on standardized patients because one, it adds more to my normals, right? Even if I do a neuro exam on somebody and their physical doesn't require it, I get better at doing my normal exam and I see more normals. And so when I do see an abnormal, it sticks out better because I've seen, thousands and thousands and thousands of normals. And so an abnormal jumps out at me every single time just because I'm so comfortable with my normal physical exam. So that's a good thing to build up. And then after you do your assessment, you need to figure out that you need to confirm or modify your plan. And your plan is based on the most likely and the most dangerous things that are going to happen, right? How do you address the most likely thing that's going to happen? And then you also validate whether you have all of the standardized equipment or any of the special equipment that was required based on the initial 9-liner mist that you were notified for. Is any gaps? Anything I forgot to mention in that?
No,
Yeah.
and every system that our medics work in is going to be different. So I think it's good that it's just a actually the CPG is a good one. It's because the military side of it, but it hits the bullet points and the pearls. So like Alfredo, you've worked in so many different systems, and I'm sure the handover has been very different setup, but they're hitting the same points. Is that right?
Yes, it all depends in terms of handover. It all depends where you're going to deliver the patient to. So you're going to go to a hospital, a specific hospital. They want to know more about a certain aspect than others. Depending if you have a patient, a cardiac patient, if you're going to hand over to a cardiologist, he wants to know exactly what's happened regarding the heart. If you have a trauma patient, it's going to be completely different. If it is a pediatric patient, it's completely different as well. So it all depends on the type of patient we have and the destination.
Yeah, kind of piling on that, Alfredo. I think even within emergency medicine or cardiologist or any of them, you'll get different personalities, right? So you'll get an ER doc that was burned because, they had an ankle sprain and missed a PE. And so every patient has a potential PE. So whenever you're talking to that provider, you have to explain how your ankle patient doesn't have a PE, right? So, personalities are across medicine, but I think I think developing a simple and consistent assessment plan that you use makes it easier for you to adapt to those different personalities. Because when they go, well, did the patient do this? Well, then chances are your normal exam ruled that in or out. You just didn't say it because it's a ridiculous thing to add, because why am I worried about that? So, yeah.
Absolutely. One thing I learned is when we arrive at the hospital, we have the 30 seconds of fame. So it means that there will be pay attention to us for about 30 seconds, and that will be it. If we start telling them things that are not relevant for them, they will completely disconnect and start talking to the nurse, and then they go away, and all the information that we have that's important will be in a limbo and may be forgotten. It will be on paper, but it will be forgotten. So I tend to use the 30 seconds that at least they can give you the information that they want, keep their attention, and then all the other don'ts, right? The patient doesn't have these or doesn't have that, probably will go back at the end and explain the rationale X, Y, and Z.
Pertinent positives and pertinent negatives. Yeah, there's a reason why you start with the positives. And honestly, I think that's the benefit of using strings, because when I start off and I say I have a sick and unstable patient, I've got your attention. I don't care who you are. I have a sick and unstable patient. I did this, this, and this because of this, this, and this. And I'm covering all of the positives right off the bat. And so, yeah, they may turn me off after 30 seconds, but they've at least heard the very important things that they need to hear to focus their attention. They might have their other 10 patients that they're worried about, right? And they have to pull themselves away to come listen to you to get this handoff. And they're like, well, the patient had Cheerios for breakfast. I don't give a shit, right? And they've already turned you off. You have nothing important. You started with Cheerios. I don't need to hear anything else. And so you need to start off with really relevant, important information. And I think it helps. So yeah, good point. Thanks for bringing that up. Yeah. So when you develop your plan, your care plan, your likely plan is going to be like, what do you need to cover for, and there's a priority of this, but I'm just listing them. So patient comfort, make sure that they're not going to be uncomfortable. And I think if you've never spent time on a litter, like more than an hour or two on a backboard, on a standardized, Skedco litter or anything, anything, you don't have an appreciation for how uncomfortable that is. You just get on there and you have no acute trauma, and you just lay on that board, you're going to realize all of those aches and pains just from laying in what you think is this, oh, they're just laying there. Well, and then throw trauma on top of that, and all that stuff is accentuated. So really ensuring that there's some kind of patient comfort for the patient to pad the appropriate areas. You want to be able to address a plan for pain. What meds are you going to give them? And do you need to set anything up like in an IV drip, or do you need to have it in syringes? Do you need to just have it available in like, I know I'm going to use these 3 medicines for this patient. I'm going to have them there. And then the ability to draw all that stuff up. So you're going to pre-position. You may not pre-draw it, but you might pre-position it, or at least put it in an area that is set aside for that patient, because it's the most likely things that you're going to have to give that patient. You have to adjust airway, like we talked earlier. Do you need to take an airway? Is it stable enough to last the duration? What is the likelihood that you're going to lose the airway, or it's going to cause complications? Those are things that need to be addressed. Yes, the patient's a litter patient. They're secured. Maybe they have a collar on. I mean, all of these things that are you're just going to get painful over time. But what if the patient is ambulatory? What if they're helping somebody else that's less ambulatory, and now you have extra 2 set of hands? Those are things. So patient movement, whether they're not going to move at all, or depending on the platform, they may have some mobility that they can move around, maybe get water or go to the bathroom or something. If your patient's litter bound, do they need to be fed? Do they need tubes? Do they need, Foleys? Are they going to have a, excuse me, how are they going to have a bowel movement? All of those things. Like, you need to plan for that depending on how long your transport is. When I start thinking about the most dangerous is any plan that I have for the likelihood, if anything fails, like if I'm counting on this tool, this monitoring device, or this infusion device, or this ventilator, or this, suction device, whatever it is, I'm planning for that to fail. So if I have a patient on a vent, what's my plan for when that vent battery dies? If I have oxygen, what's my plan for when oxygen runs out? Because we're delayed 2 to 3 times, normal planning. What is my plan for all of that? And that's how I deal with the dangerousness. Now, I can rank the dangers. What is the likelihood that something's going to fail? And what is the likelihood that I'm going to run out of something? I know that because I'm on an 8-hour movement. Very few things are going to last 8 hours. So I know that I'm going to at least use it sparingly, or I'm going to have a plan for when I can't use it anymore. So those are the things that I anticipate with every patient. When you're packaging the patient, there's a pearl that they mention in the CPG, which I really like. It's using separate straps for the patient and separate straps for each of the different equipments that you're going to use. So that's good. But I think what's not mentioned is you need to make sure that you have access to do assessments. If you put a splint on some patient, you need to be able to check a radial pulse. You need to be able to make sure that the wrap didn't convert itself into a tourniquet because of body positioning or the patient moved. You need to be able to ensure that the equipment doesn't rest on the patient, causing pressure sores in places that you don't normally look for pressure sores. Like, all of those things are factors. You need to make sure that you have access to assess the patient and access to all of the equipment, and make sure that those things don't cross. That's a big thing. And then documentation. We mentioned it briefly. So my most likely common situation is that I'm going to document at the end of the process, but you could use a piece of tape and write something. You could have a whiteboard that you can write things on. That might even be a way for your patient to communicate with you, is through a whiteboard, depending on, how loud the thing is and you can't hear. If they have a blast injury, they may not have eardrums. So their hearing's already going to be, affected. So you have a way to communicate with the patient through documentation. Last thing I would mention on the execution part is telemedicine. So having telemedicine, you may not have the advisor program. You might not have access to the advisor program, which is the pretty comprehensive telemedicine program that the U.S. military has. But when you're coming up with a telemedicine plan, my PACE plan for drawing this out is, my primary is who's going to answer the phone every time I call. There's a number. There's somebody that when I call this number, they're going to answer the phone no matter what time of day is, and they're going to provide me some information. Even if I don't have access to look things up, the person that answers that phone, that is going to answer the phone every time, they might have access and to be able to look something up on the internet, or at least look up a reference, or be a sane secondary mind that's not under the same pressures that I'm in, when I'm taking care of a patient. They might be able to give some less stressed and sound advice to me when I'm doing this. So my primary is going to be whoever's going to answer the phone every single time. Even if they tell me I don't know, they're going to answer the phone, and then now I have a person that's going to help me find the answers when I may not have the ability to do all the research that I need to do. So my backup is going to be the advisor system, or something that I can call that has more specialties than I have, that can answer some more questions in depth. You know, even if it's just an emergency room somewhere, you know, I've got emergency doctors that have their knowledge and experience, and then they have cohorts that are next to them that can provide additional information, or they can consult within their system. But emergency medicine doctors and that genre of medicine is designed to solve problems. So, you know, if I need to answer something and I don't have access to the advisor system, I can call an ER. That's a way to do it. So with telemedicine, have a plan and test it out before you need it. So if your plan is to call a number that somebody's going to answer every time, practice calling that number. Make sure it works. Make sure that it's the same number. And if it's going to be Abrick on the end of that phone when I call, you know, is Abrick on vacation, and who's answering the phone instead of Abrick, you know? So what's the plan? My third is going to be whatever local assets. My contingency is going to be whatever local assets. If I'm in, you know, South America, or, you know, Southeast Asia, or Africa somewhere, or Europe, you know, what endemic disease is local to that area, that the experts are there, right? I'm, you know, going around Africa dealing with snake bites. I'm going to go to the local station that deals with the local snakes and the snake bites, and they have the antivenom, and they can identify it, and they have, you know, at least some treatment, and they know what to treat right there. So I don't need to, you know, I could call Walter Reed and talk to them, but the local clinics have local knowledge, you know, so even pretty much at every level too. It's more common to them than it is to, you know, somewhere that's not local to them. So, and then my emergency, the last one, is going to be just a cohort or a peer, somebody that I can bounce it off of. I can call Abrick and go, hey, this is what I'm thinking. What do you think? Didn't you say you had a patient that you treated that was this such? I think I have something similar. Can you talk me through this? And it, you know, it's not an official system, but it's an external brain that can help you talk through something. You may or may not have time in the transport, but that's my telemedicine PACE plan if I can't use the advisor system. Does anybody have any similar things or any inputs to this? Because I'm 100% willing to adjust that.
So on my phone, I have a thing called the Critical app, and it's worth every penny. It's like $10, and it has everything from med calculations to drip rates to all that kind of thing. And I used it every time I flew a patient, so I didn't have to do math. Because when you have somebody that is critically ill, you need to be able to look at something and say, this is a math, show it to your partner and say, this is a math, this is what we're going to use, this is how we're going to do it. And not have to think about math in the middle of the night when you're trying to transport a pretty sick or pretty hurt patient. It's updated regularly by this nice fellow named Alan Wolf, who is incredibly smart. And like I said, I think it was $10 when I got it, and you pay, it's a one-time fee, and it's on your phone. Everybody has their phone with them. And the other thing that I did was I always had a piece of like tape on my knee that was like 6 inches wide and about a foot long. And I knew I was never going to lose my leg. I knew I would always have that piece of tape on my leg. And so when I was in the hospital giving a report to the receiving, I could go down my leg and say, this is what I did. This is the time I did it. And I knew I was never going to lose that piece of tape, and I was never going to lose my leg.
Well, those are good points. Is that Critical app, is that an Android or iOS?
I have an Apple. I think you can get it for Android as well, but I do know it's an iOS app. Like I said, I think you can get it for an Android, but I'm not 100% sure.
Okay. No, that's good. That's good information. Thank you, Angela.
They have everything. They have everything from, like I said, med calculation to pediatric drip rates to peds, it has a Broslow tape on there for you, and it has it by the color, so you don't have, like I said, especially if you have a sick kid, you don't want to have to take. You want to be able to pull something up and look at it and say, this is what I got, this is what we're going to do, and between you and your partner say, this is a good plan, this is what we're going to do.
No, that's good. That brings up some good points that I'll cover when we talk about pearls. But no, that's good. Thank you for bringing that to our attention. Critical app. Nice.
Yep.
Any other comments, suggestions?
The CoROM app has some drug calcs on it.
Is it
Our field guide app. So we have a field guide
Okay.
app that has a bunch of medical calculators on it. Not as I see the critical medical guide, if that's what she's on about from the Behringer group, looks pretty. It's 18 quid, but it looks pretty robust.
okay? No, that's
Yeah,
good.
having help.
I'm a big fan when I teach, dosing calc for medicines. I'm a big fan of having a formula on a sheet that's laminated that I can do the calculations for drip rates. I can do the same thing, the calculations for infusion rates. I have it there. Now, this is the most likely, right? Most likely is I can use an app and my battery and my phone works and I have connectivity and, I can do what I need to do. But my backup is I have this laminated sheet with the formula that I can just plug in the numbers for what dose of medicine that I want to give over how many, over an hour. What is my drip set that I'm doing? What concentration in the bag? All of those things. What type of infusion set do I have? All of those, I have that formula that I calculate, and that's my backup. Depending on the time and my level of sleep, I can do that math to verify it, and then if I have to adjust, there's, but that's my backup for that. So, got to have a backup plan. Apps are great. Going into the pearl section. These are things that were pointed out in the CPG. I have some comments that I like. We've kind of briefly discussed some of these. Some of the airway. So you need to make a decision whether you're going to secure or not. And like I said, there's no right or wrong decision. There's just consequences. And so you need to understand and take all of that and basically think through, should you take it or not? And what are the reasons for taking it? And what are the reasons for not taking it? And I think all of them are valid and need to be discussed. And it's different for every patient in every scenario. It's all different. So think through it and have a process of why you do it and why you don't. And just be able to change quickly because information changes based on status, based on personnel. All of those things are valid and need to be considered when you're thinking this through. Kind of along the lines of meds. Whether you have access to meds, if you know that your patient is a high risk of having seizures for something, and you know that you're going to fly at altitude and they might get hypoxic and you don't have supplemental oxygen. Well, how do you stop that seizure? So do you pre-draw the medicine or you just have it handy? So these are all factors, and it really depends on a lot of things, like how many patients do you have? What is the likelihood? How long are they going to be hypoxic? How long are you going to be at altitude? Is there a way for you to compensate by bagging them up and before you go to elevation? Can you talk to the air crew and have them fly lower altitudes if it's safe, so that they're diminishing or decreasing the amount of time that they're going to be at altitude where the air is thinner and they're more likely to desat if the longer they're up there. So all of these things are factors. You need to consider it. When you're going to calculate a drip on something, what does that look like? Having the right drip set or having multiple drip sets. Like there's one that you can rotate and it has a 10 drop set, a 15 drop set, a 20 drop set, and a 60. You just rotate it and it changes the dropper. I think it's about $7 US. But like if I were a medic in the field, that would be the only drip set that I would carry, because then I could just change it. It is so worth it. I wish I would have invented it. So that's, I don't know the name of it. I don't have any kickbacks. I'm not part of anything, but honestly, if I were in the fields taking care of patients all the time, I would absolutely have this multiple drip set that switches between the two. And then the formula, the formula that I have that's written out, I can change the drip set and change the math, where most of the apps that you would use, you can't do that. And so that's another benefit of kind of going caveman and just doing it by hand. It requires you to do math, and sometimes your lips will move when you're counting, and you'll have to have your phone out so you can do the calculator. But all of those things are relevant to try and do that. IV IO lines, definitely, 2 or more. 1 is none, 2 is 1. So, plan for and have more access to things. The CPG talks about dedicating certain lines to just medicines or just blood or, whatever. All of those things are factors you need to consider. And if you need another line, start another line. But even if you have one just for there, that's okay. It's better to have it and not use it than to need it and not have it. So, the assessment and reassessment, planning a sequence. So we kind of talked to this a little bit with doing your physical exam and having the consistent, but also having a pattern that you do. So if you're going to assess your patient, you can come up and talk to your patient, say, hey, how's it going? If they're able to communicate, and then you're going to gauge their response. If it's just a head injury and you're worried about TBI, then start a conversation with them so that they can communicate with you, and you're going to detect slower speech, confused answers, changed answers. As their condition deteriorates, they may not remember your name anymore, but they should remember their dog's name. And so if you intentionally tell them the wrong name for their dog, do they catch it? As tests. So there's a way for you to have an ongoing exam or, conversation with your patient to do, a running neuro exam, and you'll be able to detect changes. But how do you assess based on their injuries? Do you look at the limb? Can you access the limb and check a pulse? Can you check temperature of the limb? All of those things that you're going to be able to monitor for changes. Come up with a sequence that works for you, that you can remember, that you could do cold every time, and then just apply it to the different patients. I think overall, keeping a plan as simple as possible, because I think the definition of a good plan is not one that I can develop and carry out myself. A good plan is one that I can develop and I can hand to you, and you can carry it out exactly as planned. So that's a good plan. And those are generally going to be more simple. If I develop this ultra complex plan and I hand it to you, now it's a shit show because you didn't understand why all those things are going on there. You need to be able to keep it. So keep it simple, but keep it comprehensive. And that requires some thought. So, simple solutions now or future complications most of the time when you're taking care of patients. Oh, I'll just do this. And then later on, you're like, how did this happen? Probably because you finger drilled it earlier and you didn't think through it. You just did something instead of the right thing. And that's not always easy to figure out until it's too late. So try to think through and keep a simple plan. The last thing for pearls, we kind of covered it, this strapping. Make sure you strap the patient separate from the equipment. That's one of the pearls. I think it's a really good one. It's good to repeat a couple of times. The appendices. Now, so the first one, Appendix A, the pre-flight checklist, I think it's very good. It's part of the planning process. It's a good reminder. But if you just cover the thought process that we discussed earlier, then you're going to cover a good portion of that. Those are very platform agnostic planning things to consider. When you look at that pre-flight checklist, it's specifically for critical care evacuation. And so a lot of it is equipment, carries, medicines, different things. It's more elaborate. It's more for a specific platform. So if you're on that platform, look through it. It's good for you to be familiar with that list and run through it and kind of just highlight the areas that are relevant to your current patient movement. That's a good idea to run through, but it's always good to use some type of external brain in the planning process to trigger things that you might overlook or forget. So that pre-flight checklist is a pretty comprehensive one. The March mnemonic is good about, taking care of initial evaluation of point of injury. So I won't cover that. The equipment list, the thing that I like most about that appendix is that it follows the PFC paradigm of good, better, best progression. And I think when you're making your most likely and most dangerous plan, this is something to be considered. Like, it'd be nice to have a certain level of equipment, but what do you do when that equipment doesn't work anymore, or it fails, or the batteries run out, or whatever? So having a progression or a regression plan, like, I'd like to use this monitor, but when that fails, now I can do this, and I can access these points, and it's going to give me relevant information. When that fails, then I can do this. So I think having a progression that you can easily switch to requires that you can anticipate where those things are going to fail, and that takes a little bit of thought. So even if you just do it by system, like, all right, I'm dealing with the head. All right, these are the things that I'm using to monitor the head. When this fails, here's my backup. Here's what I'm going to do for respirations. Right? When I can't see those, I'm going to look at this. And so what are my plans for dealing with those systematic process? The Class 8 list is a good thing. A lot of times that's you're voluntold what you're going to get to carry and what you can carry. So if you have a formulary that you have access to, you can look to see to plus up on things. But I think one of the most consistent things that I get in a lot of the medical chats that I'm in is, if you were in a location and you can only take 5 medicines, what would you take? Those are nice rhetorical questions, and you probably have the same 10, 15 answers for those 5 medicines. But it depends on your history, experience, and what's worked well for you in the past. But there's a lot of good answers. You're going to get into a situation where I wish I would have carried this, but a lot of times PFC is choosing the least worst option versus the right answer. And so sometimes being comfortable, being uncomfortable is a mark of experience. When you're learning and you learn one way and you're good at one way, that's great. When that doesn't work, it's a catastrophe. When you've been doing it for a while and you have one way to do something and that doesn't work, well, you have another way to do it. And when that doesn't work, you have another way to do it. And you just find the least worst option, and that's what you go with, because that's all you have. So any fans of the 80s TV show MacGyver, that's basically what he did. So yeah, and then the telemedicine is just have a plan. All right. If you don't have access to the advisor system, come up with a plan that works for you and then test it out. If you say that there's a number that works for Abrick, well, then call him, and find out when Abrick's on vacation, or what's the backup to the ER. What is the phone number to the ER? Are there multiple ways to get a hold of, the ER? Can you call them on a radio? Can you do it on the telephone? What are your options? And test them out so that when you get into the area, you can validate what you're planning anticipated. Well, that is all that I have in my notes.
Great. So we have 8 minutes. And any questions from the audience?
Thanks, Alex.
Yeah.
Appreciate everyone's comments. That's all I got. Anything else, Abrick?
Yeah. In a month, we're going to do another CPG. So if anyone here has a suggestion on which CPG we should be doing, we're going to go through a lot of them eventually, but we have our favorites, but we wanted to open it up to yourselves. All right. Well, set a date for the next month. It'll probably be the first Saturday. We'll see how Bill's and mine schedule kind of work out. But thanks for coming, and we'll have a recording of this eventually. And yeah, welcome to the Fireside Chat.
Thanks, everyone.
Yep. All right. Have a good evening.
All right. Take care, everyone. Thanks, Abrick.
Yep. Stop recording.
You want to hang on?